yes. Okay, hi, this is Elliot Fishman, and I have my phone next to me, so Lily's going to say when we are really live, because if not, I'm simply talking to myself. I'm speaking to you from Action. I'm live? Thanks, Lily.
Yeah, live.
Good talking
Hi,
to
hi.
you. Okay, so a little bit of excitement here. I'm at Disneyland, believe it or not. I'm at the National Diagnostic Imaging Symposium. I spoke this morning on pancreatic cystic lesions. I'm speaking on adrenal today, and it's a great meeting. And today's the last day, and this will be the last afternoon. But let me show you that this is our monthly quiz. So we're going to have a bunch of good cases. Lily posted a lot of them, so you had the opportunity to look at them. So let me go through them. So this is a patient with shortness of breath and fever in the ER. Well, what do you see? You see consolidation left base, and you see patchy ground glass infiltrates without a lot of consolidation. It's really a filling type pattern, and maybe you'd think about something like hemorrhage or infection or edema. Here's the coronal views, and again, you see that it's involving upper, mid, and lower lung zones. There's fluid in the fissure. There's particularly impressive consolidation in the left upper and lower lung. And here you see very nicely the air bronchograms in the lesion. So what do you think about? Obviously, infection's a good possibility. If I told you the patient was immunosuppressed or immunocompromised, you could think of something like pneumocystis. Consolidation is atypical pneumocystis, pneumonia, but it's a thought. You can think of other ground glass infiltrates. It doesn't have the look of COVID pneumonia, but pulmonary hemorrhage, something like that, drug reaction are possibilities. And this was actually pneumocystis pneumonia in a patient with HIV. What makes it atypical is really the very dense consolidation. Another case, patient short of breath, and when you look at this case, what do you see? Well, the main thing you see are these multiple small nodules which fill in the alveoli, and it's particularly impressive. We're looking at the upper lung zones. There's also some extension of this along the fissure, and all these little tiny nodules are really nicely seen. There's more of a solid nodule in the right upper lobe, but these multiple small nodules present, something that gives you alveolar space filling. You could think about infection, that would be a thought. MAI, but it's a bit extensive. The patient also has adenopathy in the hilar regions, though you would see that better if I gave you soft tissue windows. And so this diagnosis was sarcoid. That really very nice airspace filling is really what puts you into the diagnosis of sarcoidosis. Okay, another patient with chest pain. You see the soft tissue thickening around the aorta, so the first thing you might think about is intramural hematoma, but then look how it comes to around the great vessels in the neck, and on the sagittal 3Ds, you particularly see the infiltration around the great vessels and around the aorta. It doesn't have the look of intramural hematoma. Well, what else can give you thickening? You can have vasculitis. Big vessels would be Takayasu's, would be one of them, and giant cell arteritis. But the soft tissue thickening is almost too much, and the vessels aren't so much narrowed as infiltrated around them. So things like giant cell and Takayasu's would be less likely. What if I then took you into the abdomen and showed you all of the soft tissue around the kidneys? Now you say soft tissue around the aorta and infiltration around the kidneys. Well, that's a classic diagnosis. If it was the kidneys only, you could say lymphoma, extramedullary hematopoiesis, inflammatory disease, obstruction with blood in the perirenal spaces. But when you see the soft tissue around the aorta and the infiltration of the kidney, you're thinking about one entity, and that's Erdheim-Chester disease. It's an unusual vasculitis, but multi-organ involvement, including long bone involvement, particularly the femurs. The aorta is involved in the majority of cases, particularly the arch and descending thoracic aorta, but the perinephric changes are indeed going to be very, very common. So a really great diagnosis. Again, renal changes, as we mentioned. Without the aorta, you would have a bigger differential diagnosis. With the aorta, you're going with Erdheim-Chester. Another patient, cystic lesion of the pancreas, and I showed this case in conference this morning. Cystic lesion in the body, septations. If I told you the patient was a 45-year-old female, you would say, aha. What cystic lesions in the body of the pancreas with septations? That would be a mucinocystic neoplasm. They're always considered premalignant and will be resected. Sometimes you see nodularity, and then you could say there's high-grade dysplasia. With septations like this, you're concerned, but that doesn't mean you have high-grade dysplasia. But every MCN is going to be resected, and this was low-grade dysplasia. But a beautiful MCN, there's no dilated pancreatic duct, there's no dilated common duct. Really a classic thing, and it's typically a 40-ish-year-old female. Remember, teenagers will get SPEN tumors, and 70-ish-year-old women will get serous cystadenomas. Here's another case, cystic lesion, body of the pancreas, tiny septation, no dilated pancreatic duct, and also MCN. And this was intermediate grade dysplasia, which shows you that we just really are not good at defining dysplasia. Another case. Now there's a mass in the head of the pancreas. It's not cystic, it's low density and homogeneous, and it's solid. It has some enhancement. Well, what could we be dealing with here? If I told you the patient was 40, you could say mucinocystic neoplasm and you'd worry about it. If I told you the patient was 17, you would say, aha, it's a SPEN. Interestingly, this patient was 40. We talk about SPENs, solid and papillary epithelial neoplasms, being in teenagers or women in their 20s, but it can occur anywhere through the 70s. So we've seen a number of these, and it can be a bit confusing. These tumors will all be resected, but over 90% of patients will do well with no tumor recurrence. Now let's change gears a little bit. Let's go to kidney, flank pain on the right. There's a cystic lesion in the right kidney, and it's not a simple cyst. You can see it nicely in the coronal view. There's a low-density lesion with thickened walls and septations and subtle perfusion changes. And then when you look at the excretory phase, the calyces are really deformed and destroyed. What could this be? Here's some other images. The calyces are deformed in the kidney. You could think about transitional cell carcinoma. That's the number one thing I worry about with calyceal abnormalities. The fact that cystic doesn't mean too much because the calyces can be ballooned out, but you also need to be thinking about potential infection. The infection that gives you a cystic change with deformity of the calyces is going to be TB. And this patient presented with CNS TB, also had TB on the renal biopsy and cultures. So again, a wonderful case of renal TB. Next case, patients a couple weeks post-diverticulitis. Remember with diverticulitis, you can weeks later get a liver abscess. It can seed the vasculature, but this was well-defined, sharply marginated, multiple. It doesn't look like an abscess. Looks like an infarct. This infarct's in the spleen, and when you look at the right kidney, there are multiple infarcts in the right kidney. So now we're seeing infarction of the spleen, liver, and kidneys in a patient post-diverticulitis with secondary infection, which must have led to septicemia and what ends up being septic emboli. Then with diverticulitis, you can have extension along the vessels. So just a beautiful example in the right kidney, there's nearly a global infarction. There's just some flow in the lower pole, which shows very nicely. So that was infarcts post-diverticulitis. What about this case? And I think it's the last one, fever and pain. You see in the right kidney, multiple staghorn calculi. You see a big calculus in the left kidney. In the left kidney, there's thickening in the renal pelvis around the stone. In the right kidney, the kidney looks large and cystic. When you look at it a bit closer, you're saying, aha, what gives me a staghorn calculus? Cystic changes in the kidney. What could this possibly be? And the answer would be staghorn calculus, cystic changes, loss of cortex, XGP, Xanthogranulomatous pyelonephritis. The left kidney with the large calculi and the thickening of the pelvis would also make you think of possibly XGP bilaterally, which would be exceedingly rare. Here's the patient's early phase imaging with 3D mapping with cinematic. One thing, you see the kidneys both function, at least in part. XGP often it's total non-function of the kidney, but it can be focal. And this was XGP of the right kidney and presumed XGP of the left kidney. Presenting signs, pains, frequency of urination, dysuria, palpable mass, leukocytosis. Remember, patients often presented with flank pain, and they were draining an abscess in the flank, and it ended up being a perforation and secondary abscess due to XGP. So indeed, a great diagnosis. XGP is a chronic granulomatous process. Parenchyma is replaced by lipid-laden macrophages. It's not diabetics to any degree like Xanthogranulomatous pyelonephritis is. Female more than males, average age is 40 to 50, and pyuria and positive cultures of hematuria are seen frequently. So just a really nice example. Again, big renal staghorn calculus, lack of function, dilated calyces, usually unilateral. You got to be thinking XGP. So with that, I've shown you a whole bunch of really good cases. I hope you enjoyed the cases. I hope you got the answers right. But more importantly, I hope you learned something. And if you want, drop by and say hello. I'm in Orlando for a few more hours. Sounds like a great sales pitch for someone selling used cars. But anyway, we're here, and I hope you enjoyed the talk, and have a great day. Catch you later.